Good afternoon to all. I
After
am Dr. Asavari Sawant, Public Health Specialist at IHW Council, and I welcome you all to this exclusive Guide to Good Gut Health series, an initiative by Integrated Health and Wellbeing Council and powered by JB Chemicals and Pharmaceuticals. May is the National Health Awareness Month, recognized every year by the Government of India. Integrated Health and Wellbeing Council, powered by JB Chemicals and Pharmaceuticals, has organized this initiative to raise awareness on the growing burden of gut health in children, to share with parents the guide for a good gut health. In this live session, we will discuss on the topic stomach acid disorders in children, for which we have a very eminent speaker here with us. I welcome Dr. Malathi Sathiyasekaran, who is Pediatric Gastroenterologist with MGM Healthcare, Chennai. Ma'am, we welcome you to the show.
Yes, good afternoon, Dr. Savant, and thank you for inviting me for this very interesting afternoon uh, time of discussion and questions. And I hope it will be very useful to the listeners and to the parents for in whose where they have this problem in their children. Thank you.
Great. With that, ma'am, let us get started with our queries. So, can you please explain to our audience what are stomach acid disorders and what are the different types of disorders that come under this? Over to you.
So I think even the question contains the answer. Very clearly, you have asked what are stomach acid disorders. So though the word stomach is used in this, it includes upper GI tract. It includes the swallowing tube, the esophagus, then the stomach where the food gets into and gets stayed for some time, and then also the duodenum. So normally we call this also as acid peptic disease disorders in medical terms. But it's easy for parents to understand stomach because they think everything here is stomach. So it's a common name used by lay people for anything in the upper GI tract. They will not call esophagus, stomach, duodenum like that. Everything is stomach. Wherever food enters, it is called the stomach. So problems of the esophagus, which is most common, is everyone will say, I've got GERD. It's gastroesophageal reflux, which is very common in the newborn. It is physiological or it can be pathological when it's called GER plus D. So it's disease. Stomach, you can have inflammation, just like you have redness of the eye and you call it conjunctivitis. If it gets inflamed, you call gastritis. This could be due to anything you take or medication that you take in or some infection. And it's also acid related gastric ulcer and duodenal ulcer. This will be the most common diseases or disorders. I would like to call it, rather than call disease, then everyone gets scared. Disorders seen in this stomach acid.
Thank you, ma'am. You very well explained that for our viewers who are mostly parents of younger children. So, as you were saying, that stomach acid disorders are related with anything that is related to digestion. So, is it common? Is it the same condition that affects the adults, also affecting the children, or is the physiology of, for example, GERD that you shared is different in adults and is different in children?
See that the word acid, which is used, sometimes it's very confusing. The acid may be a problem in some conditions, may not be a problem. Because acid is in the stomach. It was created for us for our good only. But anything which is not in the proper place, when it comes to the wrong place, then it will do something wrong. So that is why when you get a reflux disease, normally esophagus does not contain acid material. It contains an alkaline material. So when this comes, it finds it's something different. So it behaves differently. When the child is younger, in between, it will be more of chest pain. They may have abdominal pain more. They'll have vomiting. They may have GI bleed because of the ulceration. Sometimes they may not have any GI symptoms. They may have extra gastrointestinal symptoms like recurrent cough, hoarseness of the voice, breathing problem, and all that. So these are the things. When you're younger, then it is much more different because they may have vomiting, then they may have failure to thrive because of vomiting, then they may have apneic spells, recurrent cough, they may have pneumonia, aspirations when they are much younger. So imagine that the symptoms are all different in different age group and one should know them. Just failure to thrive. Maybe the presentation in a child less than 1 year of age, and just cough and vomiting may be a problem in a child 3 to 5 years. As they grow older, you will get the heartburn and
Thank you, ma'am. Ma'am, we also want to know what might be the causes for these GERD and GER conditions in children. What could be the risk factors that could lead to child having this problem?
see actually causes when we look at normally why are you and not having the reflux now? We are sitting happily. Dr. Samant, you had your lunch, but you're not burping and belching. I'm also not doing that because our esophagus, everything is in a balance. We have aggressive factors and we have defensive factors. Both are going in a very good balance. We have very good defensive factors. Like, the esophagus has good peristalsis, so you push off the acid as soon as it comes, like a policeman, chase them off quickly. And then you have a good sphincter, then you have a good diaphragm, then you have a good stomach which empties. So you see that the acid is preventive. Aggressive factors are very few, which may be a little bit of acid and pepsin and things. So what is happening is either this becomes little lax, this closing is not very good, or a portion of it goes up, or because of your medications or the food that you take, it is opening more frequently, or because of your lifestyle, it is opening more frequently, or anatomical itself, this door is not working properly. Instead of closing after you eating, you have what is known as the transient lower sphincter relaxation. When it should not open, it's opening. Because if it opens at the right time, it will also be ready to neutralize. It will be ready to fight the acid. If it opens at the wrong time, it's not aware acid is going to come, so it gets caught. So this is the most common cause of esophagitis. This opening when it should not open. So when should it open? The door, it should open only when you eat, when you have peristalsis, when the food goes down, then it will neutralize. So the most common cause are these anatomical problems. High acid output as such, earlier we were talking about that. We were talking about hurry, worry, curry, and then we said only this will cause. Then we said as no acid, no ulcer, that is also gone. So now we realize, it is a sort of food which you take, your food habits, and this opening up of the sphincter when it should not open, or the transient lower esophageal sphincter relaxation, in addition to hiatus hernia, diaphragmatic movements. Sometimes your esophagus doesn't work well. When the acid comes up, it should push it down. The movement is not good in the esophagus, then it will not push it down, then you get the reflux.
Thank you, ma'am. Ma'am, we all were also concerned about this thing that if the baby is suffering from some sort of systemic disease, can that also cause GERD in their bodies? Is it
Yeah.
possible?
Systemic diseases like, if they have, mainly it will be like cerebral palsy or neurological problems, because that's in necessary. That's why I was telling you about the swallowing. So a good peristalsis is necessary. We always think the swallowing tube is a tube. Put the food, it will go down with gravity. It's not like that. It goes in by peristalsis. And the peristalsis should be propulsive. It should be propagative. It should keep moving downwards. So when the acid comes, it will immediately push the acid down, if it is good. So suppose you have a neurological problem, cerebral palsy, you have swallowing disorders, then you will not push it down. So there are other disorders also like this where you can have, most of them are the neurological disorders where you can have a cerebral. In addition, connective tissue disorders, which you may not be aware about, scleroderma, all that can also have these muscle disorders where you can have. So either connective tissue disorders where it doesn't push it down, or you can have a neurological disorder.
Thank you, ma'am. That very well explains and makes us understand on these aspects. So, coming on to the diagnosis of GERD, can you please help us understand how is this diagnosed? What all different tests are prescribed routinely, and how, just to inform parents that how is this process works?
See, as I was telling you, GR is very, very common. 70% of less children less than 6 months will have. And then you have the GRD. And actually, there's no third test for the diagnosis. It is more the history. So if we have a child who's vomiting frequently and it is non-bilious, so the most important is most of them are non-bilious. It will occur soon after food, and the child has chest pain. We look at the combination. So history is still a very important tool, even in this era of high-tech investigation where available. Even in 2023, if you must get the history, no use going and doing it for a child. I have had children brought thinking it's GRD, and finally it was a child with a brain tumor. Why? Because the parents also didn't notice that the child had some problem in walking. The doctor did not ask. Vomiting immediately referred for endoscopy, GRD. So there are some, along with vomiting, there should be something. Suppose the child has cough, cough, cough. Yesterday, one child, madam, I think this is GRD, please do endoscopy. You ask and they're saying, no, no, no. Every time the child coughs, only it is vomiting. That is not GRD. That is post-tussive vomiting. So suppose the child has urinary infection, has fever, dysuria, vomiting. That is because of urinary infection. So GRD is first history, but we do endoscopy in some when we have red flag signs and we want to know the effect of reflux on the mucosa. We do 24-hour pH later to find out, document, yes, this is acid reflux. Because when you have the milk, you will not have somewhere where facilities are available. They even do impedance testing. We do manometry in our center because we have the instrument. But these are all only for a very, very few. We stop with history and endoscopy. Endoscopy, especially when we want to exclude other conditions like eosinophilic esophagitis. We think it may be an allergic esophagitis, something like that. We want to take a biopsy, or there's something different in the history. There has a GI bleed also. Then we do that. And if we have 24-hour pH, we do barium swallow, no use, don't do radionuclide studies, don't do a CT brain when you're suspecting GRD. So where the parents should understand, GRD is not something which you have to be so worried about. My infant has GERD. What is wrong in GERD? Nothing is wrong. Everything will become all right. So after some time, it's going to become all right. Don't push your child to more investigations. Write down the history, write down the complaint, and you will be able to find out what is the.
Ma'am, this is one of the very strong points that you have highlighted amongst others, that vomiting and upset stomach can be related to many other diseases. And just because the child has experienced vomiting does not mean that he is detected of GERD instantaneously and you start, getting treatment for that. Sharing with the doctor the entire history of the patient, the complete picture, giving them your valued information and time about the child that you know is just as important to detect any other hidden diseases that might be there under the realm of vomiting that is superficially present. So coming on to the next aspect, how do we really classify that this is pathological acid disorder and not just normal physiological reflux to something that the child might have taken in?
Very simple is, see whether what we call warning signs or red flag signs. See, suppose the child is losing weight, not gaining weight, the child is not sleeping, child has a GI bleed, child has fever, very irritable, and when we examine, if we find child has a bulging fontanelle or has hepatosplenomegaly, or doesn't look well, requiring admission, hospitalization, those are the GERD. GR, the child will be happy spitter. It will be spitting and smiling. Only the parents will be anxious. Vomiting everything, doctor. Vomiting everything, everything. Because that is a mother. She will think and vomit, but I have to document the weight and tell her, see, even if it vomits everything, look at the weight. So something is going in enough for the child. So this is common positing, and that is why earlier we used to have a bib which we used to tie for the baby, and the baby will say, I'm a happy spitter. Now parents don't want to tie a bib also. There's no bib. So they come to us without a bib and they will keep on saying, it's not vomiting, that is called positing or regurgitation. When you use the word vomiting, we have to take little more seriously. It will just come passively. Child will be happy playing and just come out. And it'll again play and it'll again drink. So it's very different. So first simple thing is no warning signs, no red flag signs. If there are no warning signs, no red flag sign, it is physiological. Physiological, yes, even during pregnancy, when you're really happy, when someone vomits during, they say, oh, you become pregnant. It's like that. So there you're not too worried unless it becomes hyperemesis.
Got it, ma'am. Understood. So, on the same note, if the child has been detected of GERD, what are the different treatment options that are available for this? And how do doctors usually go about it?
So first, as I told you, even in 2023, ours is a history. We take it down because we don't want to miss, like I told you, something different and treat it as GERD. Anyone, even the pharmacy man can treat. You go and tell him he'll give you the same medicine which I write. Because everyone knows. And here you can get it OTC. So if you really want to think how to treat, one is just lifestyle modifications, diet. Second is medical. Third is endoscopic management has come. Fourth, we have surgical management. All the four options are there. Remember, surgery, endoscopy will be only for those severe forms. We'll keep it separately. Lifestyle modifications for everyone. What can you do for a child? Lifestyle modifications when it's an infant, suppose it's very small. What we try to do, we try to use the physics of thickening the feeds so that it doesn't come up. So if a child is on top feed or is on commercial formula, we add a thickener like, rice paste to the milk, 1 scoop, 1 teaspoon for every 30 ml. For breast milk, you cannot do. And even if you extract express it and add, you cannot add because it will dissolve. But all the top feeds you can use as a thickener. As they grow older, you try to give them small, thick feeds. Avoid this too much of dilute feeds and space out the feeding. Ask them not to lie down soon after meals. The best position for an infant would be just, a left lateral, or don't put them prone. Though prone is good, you have to be careful because of sudden death in infancy too. We don't try to push them on a supine position. We just keep them little left lateral and raise the head end so that, this is just normal. You know that. If it's flat, then it will come out like a bottle. So if you keep them like this, then the chances of it coming into the stomach being more. You turn them little bit to the right so that it goes into the duodenum quickly. That's all, just empty. Keep them like that for some time, or you hold them here. They will outgrow. Most of them will outgrow. Older, we try to avoid any food which will open up the sphincter, like fatty food, deep fried food, like a samosa, butter. You should not take, but don't take that frequently. Mint, chocolate, oily foods, capsicum, all that will open up. Certain medications will open up, like salbutamol, theophylline. Hormones will open it up. Surgeries will open up. These are lifestyle modifications which we do in the diet as the medication. Either we can decrease the acid by medication, we can coat the ulcer by giving a medication, and these are the main things which we use. Or we use something like a buffer to prevent the acid from coming in. The medications, just neutralizing acid, the volume required is too much, so we don't use. The most commonly used drugs are those which suppress the acid. There are two groups. One will be the ranitidine group and the other is the proton pump inhibitor. And at present, proton pump inhibitors are supposed to are the best in the healing of ulcers. Maintenance, you can either use these two.
Thank you so much, ma'am. So, ma'am, you were also able to cover the point that I was about to ask next. That is there any food specifications? So, for older children, you have suggested to avoid oily greasy,
Yeah.
fatty food, so that this problem does not aggravate. Is there any specific recommendations for younger children as well, or infants, to avoid those things, or take something more that would help
Yeah.
in the proper digestion?
Thickening feeds. Avoid chips, but younger it's mainly the thickening because you try to use the gravity to bring it down. And then that's the only thing which you can do. And you thicken the feeds. Thickening the feeds has definitely helped. Thickening are available abroad, but here in India we don't have. But we use the rice cereal as a thickener for the thing. And the porridge or whatever we give it in that consistency. So probably like a batter consistency or dosa batter consistency rather than making it very thin. So that consistency, it is good for the child to give. And we avoid all these aerated drinks. Don't give aerated drinks. Don't give them chocolates too much. And then cocoa opens up the sphincter more.
Okay, ma'am. Thank you. So, ma'am, are there any guidelines for appropriate timing and frequency of meals for children as well for this? Are there any
No,
specifications
actually,
like
we
that?
don't. We try to avoid making them feel like a patient because the mother already is so thing. We should not give them things. The three main meals they should take, like the others. It's a family food only. So three main meals will be that breakfast, lunch, dinner. Two snackings in between 10 and 5 they will have. That is all. Don't have to keep on feeding them unless it's a 1 month. Even then, the basis is the emptying time of the stomach is 3 to 3.5 hours. So it's no use pushing food. There's no need to keep on pushing food. Nothing like that. Just allow the child to play, be happy, and then the stomach it will empty. Once the stomach empties, this reflux will come down.
Thank you, ma'am. So, we are coming on to the very end of our session today. Just two more questions for you for today. One of them is, are there any specific signs or symptoms that parents should be aware of that may require immediate medical attention? So something that they should be very aware of.
Young infants, I think, suppose the child is aspirating frequently. Every time they feed, if the child starts coughing and aspirating, it is a very severe form of reflux disease that they should be very careful about. If the child is not growing well, as reflux has vomiting, but somehow they find it's not growing well as the peers, and then it vomited and there was little blood. Those are symptoms I think they should bring the child, not for just one vomiting in a day, went out, had something and a vomiting, that they need not get worried. But certain symptoms, as I told you earlier, also the warning signals or the red flag signs should be noted by the parents.
Thank you so much, ma'am. So,
Thank
and
you.
coming on to the very last question, that is, as all the parents are watching today this show on stomach acid disorders, what would be your advice to those viewers who are watching for managing or doing well with kids who are already facing such issues?
I think the best would be to give them, the food which their parents gave them. That's very, very important. Give more fruits, more vegetables during tea time. What is shown on the TV is actually good for health. It is good on the TV. So all that, try improving that. Initially itself, we should allow them to taste the food like this, and they will enjoy that food. But from the beginning, if we give them a packet of chips and then try to give them something like that, try give a packet of biscuit, and in that biscuit also they like cream biscuit, you cause both obesity as well as reflux. I think that is the most important, and try to constantly avoid medications for your children. Any small illness symptom treatment, immediately run to the doctor, and that doctor in this hurry, they will give one antibiotic, they will give one medicine. Just wait for some time. Ensure that all immunization is given. Ensure that if you have a newborn baby, give exclusive breast milk till 6 months of age. That is very, very important, and it continued to the age of 1 year. And the diet style, as I told you, be like that. And if they have, in addition, like hyperreactive AV disease, they may vomit, but be careful with those children. If they are not growing well, I think they should be a little more careful.
Thank you so much, ma'am. We thank Dr. Malathi Sathiyasekaran for taking out time from your busy schedule and imparting us with wealth of knowledge and information today. Thank you so much. We are in, yes. We are in the National Health Awareness Month, which is the month of May, and we hope this initiative was of great value to you and imparted you with, new information that would be applicable in your life, or somebody that you already know you can share it with them. So thank you so much. With that, we also thank our partner JB Chemicals and Pharmaceuticals for partnering up with this activity and for raising awareness on this very essential topic of good gut health. Thank you so much. We would also like to thank our viewers for staying with us till the very end. With that, we sign off now. Thank you. Have a nice day. Thank you.
Thank you.